The pulmonary function test, or PFT, is a non-invasive way of measuring how well the lungs are working. Essentially, it evaluates lung volume and breathing capacity, then compares the results with what would be expected for a healthy person of the same age, sex, race, height, weight, and smoking status. The purpose of this test is broad. It can reveal hidden lung impairment before symptoms begin, provide objective information to help decide whether a treatment should be continued, changed, or stopped, and assess the risk of complications after surgery. It is also used to understand the cause of shortness of breath, or to evaluate how a patient's occupation may have influenced lung function. The method itself is straightforward. The patient is instructed to breathe deeply and then exhale forcefully into a spirometer, which records the volume and the speed of airflow. Other specialized methods include the open-circuit nitrogen technique, where the patient inhales 100% oxygen while exhaled gases are collected, and the closed-circuit helium method, in which helium mixed with air is inhaled and its concentration changes are used to calculate total lung capacity. Preparation before the test is important. Patients are reassured that the procedure is safe and not harmful to the lungs, even though it can feel tiring. They are told that accuracy requires breathing only through the mouthpiece, with the nose clipped shut. The test is usually performed on an empty stomach, because stomach distension can affect lung expansion. Inhaled bronchodilators are typically withheld for several hours before the test unless otherwise instructed by a physician, and smoking should be avoided. Loose clothing is recommended, and the patient should be seated or standing comfortably. During the procedure, the patient breathes normally a few times, then inhales deeply to fill the lungs to capacity before exhaling completely. The machine measures the volume and the time required. Because the test involves repeated forced breathing, patients are monitored afterward for shortness of breath or bronchospasm, and it is noted whether bronchodilators were given during the test. Turning to the gastroscopy, or GFS, this procedure is performed in patients with gastrointestinal bleeding, pernicious anemia, esophageal damage, difficulty swallowing, chest pain, or discomfort in the upper abdomen. The technique begins with local anesthesia of the throat, using a spray or gargle solution, and often a sedative is given intravenously. The patient lies on the left side with a towel or kidney tray placed near the mouth, and a plastic mouthpiece is used so that the scope is not bitten. A flexible endoscope is passed through the mouth into the esophagus, stomach, pylorus, and duodenum. The scope is equipped with a light, a camera that can capture color photographs, and channels for biopsy instruments so that tissue samples can be taken or small polyps removed. During insertion, the patient may be asked to swallow once, but then must keep the throat relaxed, avoid talking, and allow secretions to drain to the side for suctioning. To improve visibility, air is gently introduced into the stomach, which may cause some temporary bloating or belching until it is removed at the end of the exam. Before the test, several steps are essential. Patients must fast for at least 8 hours to prevent aspiration. Dentures or removable bridges should be taken out, and medications such as atropine may be given to reduce secretions. Sedatives like diazepam or meperidine are used to reduce anxiety and make the procedure more comfortable. Topical anesthetic is allowed to remain in the throat for a few minutes to reduce the gag reflex. After the examination, patients are monitored closely. Vital signs are checked frequently, and they are kept in a lateral position until the effects of anesthesia wear off to reduce the risk of choking. Nothing should be taken by mouth for 2 to 4 hours until the swallowing reflex returns. Mild throat soreness is common, and gargling with saline or using soothing medication may help. Serious complications such as bleeding, fever, difficulty swallowing, or signs of perforation, like neck pain, chest pain, shoulder pain, or difficulty breathing must be carefully assessed. Small amounts of gas, belching, or bloating are normal after the test because of the air introduced during the procedure. The sigmoidoscopy, often called a flexible sigmoidoscopy, is an endoscopic procedure used to examine the distal sigmoid colon, the rectum, and the anal canal. A soft fiber optic tube is gently inserted through the anus, allowing the examiner to visualize these regions directly. The purpose of the exam is to diagnose both benign and malignant tumors of the anal canal and rectum, as well as to evaluate conditions such as hemorrhoids, polyps, fissures, fistulas, and abscesses. During the procedure, the anal sphincter is gradually dilated, and the flexible scope is advanced about 25 to 30 centimeters through the anus, reaching the distal sigmoid colon. This enables inspection of the rectum and part of the descending colon, and suspicious lesions can be biopsied. In some cases, a rigid proctoscope may also be used, usually inserted for just a few seconds, to provide a direct look at the lower rectum and the anal canal. Preparation is essential. Patients are informed about the procedure, the expected position, often the knee-chest or left lateral position, the sensation of discomfort as the scope passes, and the fact that the rectum is sensitive to temperature changes, so the scope may feel cold. For a full colon examination, patients usually follow a clear liquid diet for 24 hours, take laxatives the evening before, and undergo bowel cleansing on the day of the test, often using polyethylene glycol solution. However, in cases of bleeding or severe diarrhea, the test may proceed without bowel preparation. After the procedure, patients are monitored for complications such as bleeding, pain, or fever, and any tissue samples are promptly sent to the laboratory. To prevent postural hypotension or fainting, patients are advised to rest in the supine position for several minutes before standing. If discomfort persists, sitz baths may be prescribed. Moving on to the bronchoscopy, this is an endoscopic examination of the trachea and bronchi using a fiber optic bronchoscope. The test is performed when there is unexplained chronic cough, hemoptysis, suspected bronchial obstruction, or abnormal findings on chest X-ray. It is also used for tumor evaluation, biopsy collection, localization of bleeding, and treatment of pulmonary abscesses, pneumonia, or aspiration. In addition, it helps remove foreign bodies, crusts, or thick secretions that cannot be cleared by suctioning. The procedure takes place in an operating room or radiology suite, with the patient either sitting or lying supine. Oxygen is administered, blood pressure is monitored, and the flexible bronchoscope is inserted through the nose, mouth, endotracheal tube, or tracheostomy site. Contraindications include severe asthma, massive hemoptysis, advanced heart failure, or unstable arrhythmias. Before the test, patient anxiety is reduced by explaining the procedure thoroughly. The patient must fast for 6 to 12 hours, dentures are removed, and informed consent is obtained if general anesthesia is used. Allergies to iodine, local anesthetics, or other medications are carefully checked. Premedication may include atropine or diazepam. During the exam, a sedative is given intravenously, and local anesthetic is sprayed into the nose or mouth to suppress the gag reflex. Patients may feel dryness of the mouth, swelling of the tongue or throat, or difficulty swallowing, but are reassured that breathing remains unimpaired. After the procedure, vital signs are monitored every 15 minutes until stable. Conscious patients are placed in a semi-sitting position. Unconscious patients are kept with the head slightly elevated and turned to the side. Secretions should be spat out into a basin or tissue, rather than swallowed. Patients are warned that forceful coughing could dislodge clots and cause bleeding. Careful observation is needed for subcutaneous emphysema, which may signal tracheal or bronchial perforation. No food or drink is allowed until the gag reflex returns. If hoarseness or throat pain develops, ice packs may be applied around the neck. Saline gargles can be used, and patients are advised to avoid smoking, talking, or coughing for several hours. Finally, clinicians monitor for dangerous complications such as laryngeal edema, bronchospasm, hemoptysis, pneumothorax, or severe respiratory distress. The colonoscopy is an endoscopic examination that allows doctors to inspect the entire colon, from the anus all the way to the cecum. The main purpose of this test is to identify benign and malignant tumors, polyps, or active bleeding sites. It is also performed for patients who have positive fecal occult blood tests, unexplained changes in bowel habits, lower gastrointestinal bleeding, or who are at high risk for colon cancer. In addition, it allows insertion of instruments through the scope to obtain biopsy samples. During the procedure, the patient is usually placed in the Sims position, and the colonoscope is gently advanced through the rectum or a colostomy site toward the cecum. Complete examination of the colon requires skilled manipulation of the scope. As with all endoscopic procedures, air is insufflated into the bowel to improve visualization of the mucosa. Because of this, patients may experience cramping or abdominal discomfort. The procedure generally lasts between 20 and 60 minutes. Before the test, patients are asked to fast from midnight, even if the exam is scheduled for the following afternoon. For bowel preparation, a solution such as Colon Light, 4 liters mixed with water, is consumed starting at 6 in the morning, over about 2 hours. If no watery stools appear after 4 hours, a 1-liter saline enema may be given. Patients should avoid fruits with seeds for at least 3 days prior to the test. Sometimes a sedative, such as Demerol, is administered, and any rectal bleeding or abdominal pain is carefully monitored. After the procedure, vital signs must be checked frequently, and any severe abdominal pain, rectal bleeding, or fever should be reported immediately. Because sedatives are given, patients should not drive immediately afterward. If no complications such as perforation are suspected, a regular diet can usually be resumed. Hydration is important, since bowel preparation often causes fluid loss, so patients are encouraged to drink plenty of water. The echocardiography, or heart ultrasound, is a non-invasive imaging test that uses sound waves to create real-time pictures of the heart. It allows doctors to see the heart's structure, measure cardiac function, and even estimate pressures inside the heart without surgery. Because of its accuracy, it is widely used in the diagnosis of heart disease. There are several types: the standard transthoracic echocardiography, transesophageal echo, exercise stress echo, pharmacologic stress echo using dobutamine, ergonovine stress echo, myocardial contrast echo, and even 3-dimensional echocardiography. The most common form is the transthoracic echocardiography. In this test, the patient usually lies on the left side in a slightly tilted position. The examiner typically stands on the patient's right side, holding the probe close to the chest wall, and captures moving images of the heart on the monitor. This allows direct assessment of heart chambers, valves, pumping function, and any structural abnormalities. The transesophageal echocardiography, or TEE, is a special form of ultrasound imaging that provides a much clearer and higher quality picture of the heart than standard surface echocardiography. Because the ultrasound probe is placed inside the esophagus, which lies directly behind the heart, doctors can obtain sharp, detailed images of the atria, ventricles, valves, and great vessels. TE is performed when patients have chest pain, abnormal ECG findings, or when a chest X-ray shows enlargement of the heart. It is also useful in diagnosing congenital heart disease, coronary artery disease, cardiomyopathy, or pericardial effusion. Importantly, TEE is often used when standard transthoracic echo cannot provide an adequate image, such as in patients who are obese, who have chest wall injuries, or who suffer from chronic obstructive pulmonary disease. The procedure is fairly straightforward. To reduce discomfort when inserting the probe, the throat is numbed with a local anesthetic, often given as a liquid that the patient holds in the back of the mouth before swallowing. The patient then lies on their left side. A bite guard is placed between the teeth to protect both the patient and the probe. The flexible endoscope-like probe is then gently guided through the mouth, down the esophagus, and into position just behind the heart. The exam usually takes 20 to 30 minutes. Because saliva builds up during the test, patients are instructed not to swallow, but to let secretions flow out of the mouth. Discomfort is similar to that of a gastroscopy. Before the exam, patients must fast for 8 to 10 hours. They also need to remove dentures, glasses, or contact lenses, and sign a consent form after hearing a full explanation of the procedure and possible side effects. An IV line is established, and sometimes a sedative is given to help the patient relax. During the exam, vital signs are carefully monitored. Afterward, patients remain on bed rest until the effects of anesthesia and medication wear off. They should not eat or drink until swallowing reflexes return, usually after 2 hours, and then start with soft foods and plenty of fluids. A sore throat or hoarseness may persist temporarily. Nurses and doctors observe for complications such as bleeding, chest pain, or signs of esophageal perforation. Although rare, arrhythmias or perforation can occur. TE is contraindicated in patients with esophageal varices or significant esophageal disease. Another important test is the stress echocardiography. This test evaluates how the heart responds under stress, either with exercise or with drugs that simulate exercise, such as dobutamine, adenosine, or ergonovine. Patients must first provide consent after the physician explains the purpose and risks. If medications are used, an IV line is placed. If exercise is chosen, the patient runs on a treadmill or pedals a stationary bike until maximum effort is reached or chest pain or other concerning symptoms appear. Immediately afterward, ultrasound images of the heart are obtained in positions similar to a transthoracic echo. Stress echocardiography is a powerful tool to detect coronary artery disease and to assess heart function under load. Cardiac catheterization is one of the most invasive, but also one of the most accurate tests for heart disease. Using X-ray guidance, a thin flexible tube called a catheter is inserted into the heart to measure pressures inside the chambers, record cardiac output, assess oxygen saturation, and visualize structural abnormalities. This test is often combined with coronary angiography. We perform catheterization in several situations. It is indicated when coronary artery disease, cardiomyopathy, or valvular disease is suspected, when angina is severe or unstable, when heart failure or life-threatening arrhythmias are not controlled by medication, and when we need to decide whether surgery or interventions such as angioplasty or bypass are appropriate. It is also used to evaluate the effectiveness of those treatments. There are two main approaches. In right-sided catheterization, the catheter is inserted through a vein, often the basilic or femoral vein, and advanced to the right atrium, right ventricle, pulmonary artery, and pulmonary capillary wedge position. Pressures are measured, and blood samples are taken for oxygen analysis. Contrast dye can be injected to look for valve regurgitation or abnormal shunts. In left-sided catheterization, the catheter is introduced through an artery, such as the femoral or brachial artery, then advanced retrograde across the aortic valve into the left ventricle. Another technique punctures the interatrial septum to reach the left atrium. Once in place, contrast dye and special medications allow us to measure ventricular wall motion, thickness, end diastolic and end systolic volumes, stroke volume, and ejection fraction. The test takes 1 to 3 hours. Patients must fast for at least 6 hours beforehand, and IV access is established in case of emergencies. Contraindications include acute myocardial infarction, severe decompensated heart failure, or serious uncontrolled arrhythmias. Coronary angiography is performed to visualize the coronary arteries themselves, the vessels that supply blood to the heart muscle. It helps us identify narrowing, blockages, collateral circulation, and the exact location of disease. The catheter is advanced through the femoral or brachial artery until its tip rests at the opening of the right or left coronary artery. Then a small amount of contrast dye, usually 2 to 5 milliliters, is injected while X-ray images are taken to follow the flow. Because the dye can briefly reduce blood flow, patients may feel transient chest pain, warmth, or nausea. Sometimes nitroglycerin is given under the tongue, or antianginal drugs are injected to dilate the artery and improve visibility. If the dye causes slowing of the right coronary artery and bradycardia, atropine may be administered intravenously. Before the procedure, patients receive full information, emotional support, and must sign consent. Baseline studies such as chest X-ray, ECG, blood counts, and urinalysis are performed. Patients fast from midnight, though light breakfast may be allowed if the procedure is in the afternoon. The insertion site is shaved and disinfected. Mild sedation is often given. The patient is told what to expect: palpitations, a hot or flushing sensation, or a tickling cough when dye enters the heart. They must remain lying flat throughout the procedure. After the test, vital signs are checked frequently. The nurse watches carefully for sudden changes, bleeding, swelling, or signs of embolism. Heart rhythm, urine output, and the insertion site are monitored closely. Adequate fluids are encouraged to flush out the dye. Pain or discomfort is relieved with prescribed medication. The limb used for access must remain straight and immobile for 4 to 6 hours, sometimes with a sandbag applied for pressure. Possible complications include myocardial infarction, stroke, arterial bleeding, arterial thrombosis, and severe arrhythmias. While rare, they are potentially life-threatening, which is why this invasive but powerful test is carried out under strict monitoring. Endoscopic retrograde cholangiopancreatography, or ERCP, is a special procedure that allows us to examine and treat problems of the bile ducts and pancreas. It is usually performed when a patient presents with jaundice, especially if bilirubin levels are higher than 3.5 milligrams per deciliter, or when biliary obstruction is suspected. We also use it for patients with upper abdominal pain, or when blood tests suggest chronic pancreatitis or sclerosing cholangitis. ERCP is both a diagnostic and a therapeutic tool. Through this procedure, we can confirm the diagnosis, obtain tissue samples, relieve obstruction by dilating the ducts, perform a sphincterotomy, insert drainage tubes, or even remove gallstones. The procedure itself takes about 20 minutes to an hour. A flexible fiber optic endoscope is inserted through the mouth, passed down the esophagus, and into the duodenum. To make visualization easier, a small amount of secretin may be given intravenously, which reduces duodenal motility and helps us clearly see the ampulla of Vater. A catheter is then positioned at the papilla, and contrast dye is injected. To prevent septicemia caused by bacteria entering the bloodstream under pressure, broad-spectrum antibiotics are administered. Before the test, the patient is educated about the purpose and the steps, and reassurance is given to reduce anxiety. A written consent form is signed, dentures, or metal objects are removed, and fasting for at least 8 hours is required. A venous line is secured for safety, and baseline amylase levels are measured to help us detect pancreatitis afterward. Local anesthetics, defoaming agents, and sedatives are used to ease discomfort. After the procedure, we watch closely for complications such as perforation, bleeding, pancreatitis, or sepsis. Vital signs are checked frequently. Some bloating or abdominal discomfort is expected since air is introduced during the exam, but this resolves naturally with time. Eating or drinking is allowed only after the throat anesthesia has worn off, usually about an hour later. Patients are instructed to report immediately if they develop severe pain, fever, vomiting blood, passing blood in stool, or black tarry stools. ERCP is not performed in patients with bleeding disorders, severe strictures that prevent passage of the scope, or in those whose general condition makes the procedure unsafe. Although uncommon, complications such as shock, sepsis, or pancreatitis can occur. Magnetic resonance imaging, or MRI, is a non-invasive imaging test that uses a strong magnetic field and radiofrequency waves to produce highly detailed pictures of the body. Unlike X-rays or CT scans, MRI does not use radiation. Instead, it excites hydrogen atoms in the body with bursts of radio waves. When the radio waves are turned off, the hydrogen atoms release energy, and this signal is captured to form images. Because of this principle, MRI provides excellent contrast for soft tissues, making it particularly valuable in evaluating the nervous system, the musculoskeletal system, and the cardiovascular system. During the exam, the patient lies on a narrow table that slides into a cylindrical scanner. The machine is open at both ends, so the patient can see out, but some still feel confined, so reassurance is important. The test requires stillness throughout, because even small movements can blur the images. The examination usually lasts between 30 and 90 minutes, depending on the area studied. Sometimes, a special coil or local antenna is placed over the body part of interest to enhance image resolution. If necessary, a contrast agent may be injected intravenously to highlight tissues or blood vessels. Patients will hear loud knocking or tapping noises during the scan, so earplugs or headphones may be offered. Preparation includes avoiding food for about an hour before, and avoiding alcohol or caffeine for 2 hours. All metal objects must be removed: jewelry, watches, credit cards, or anything magnetic. Patients wear a hospital gown without metal fasteners. A careful history is taken, especially regarding pregnancy, pacemakers, aneurysm clips, prosthetic valves, or other implanted devices that could move in the magnetic field. For children or patients with claustrophobia, mild sedation may be used. After the scan, normal activities can usually be resumed immediately. If contrast was injected, the IV site is checked for redness or swelling, and fluids are encouraged to help flush the agent from the system. In rare cases, mild phlebitis or allergic reactions may occur. Patients and families are reminded that the results will be reviewed carefully, and if abnormalities are found that require surgery or further treatment, the healthcare team will provide guidance. Computed tomography, or CT of the chest, is a highly detailed imaging technique that allows us to evaluate the chest in much more depth than a simple X-ray. We often use it when an abnormal vascular pattern is seen on a chest radiograph, when lung cancer is suspected even though the chest X-ray looks normal, or when we need to distinguish whether an opacity is due to tuberculosis cavities, lung abscesses, or calcifications. It is also used to evaluate suspected tumors of the mediastinum, ribs, or spine. During the exam, the patient lies supine on the CT scanning table, although lateral or prone positions may also be used. While the scan is in progress, the X-ray tube rotates around the patient's body, moving either in a circular path or in a figure-8 pattern. The patient must remain completely still but is instructed to breathe normally, since the exam does not usually require holding the breath. In terms of preparation, there are no restrictions on food, drink, or medication before a chest CT. Sedation or anesthesia is not typically required. Patients should, however, be reminded to lie still throughout the test. For women, it is important to check for the possibility of pregnancy, so the date of the last menstrual period is recorded. All metal objects such as dentures, jewelry, eyeglasses, or hairpins must be removed, since they can interfere with imaging. Baseline neurologic status and vital signs are assessed beforehand, and if there is any suspicious drainage, for example from the ear or nose, it may be tested with glucose strips to rule out cerebrospinal fluid leakage, which must be reported immediately. After the scan, vital signs and neurologic status are reassessed, and the results are explained to the patient and family with support and reassurance. Intravenous pyelography, or IVP, is an X-ray study of the urinary tract that uses contrast dye to visualize the kidneys, ureters, and bladder. It is performed to diagnose structural defects, tumors, partial or complete obstruction caused by stones or strictures, and to evaluate the rate of dye excretion in order to identify glomerular abnormalities. It also helps in diagnosing renal artery occlusion, congenital anomalies, traumatic injuries, hematomas, and changes in kidney size, shape, or position. IVP is especially useful in cases of hydronephrosis, polycystic kidney disease, or suspected residual urine in the bladder. The procedure begins with the patient lying supine on the X-ray table, draped for privacy. A plain abdominal film, often called a KUB, is taken first to check for stones, fecal matter, gas, or residual barium that might obscure the view. An intravenous line is then established, and contrast dye is injected. The patient is asked to report any nausea, flushing, or sweating that may occur. Sequential X-rays are taken at specific intervals, commonly at 1, 5, 10, 15, 20, and 30 minutes, until the contrast reaches the bladder. By 5 minutes, the dye is usually concentrated in the renal tubules, making it possible to obtain detailed nephrogram images. After the initial films, the patient is asked to void, and a post-void image is taken to check for residual urine. If detailed views of the ureters are required, a compression device may be applied around the abdomen to temporarily hold the contrast in the upper ureters, then released to let it flow into the bladder. Additional tomography may be added to examine renal layers or masses more clearly. During tomographic imaging, the X-ray tube and film cassette move in opposite directions, creating thin slices of the kidney for better evaluation. IVP should not be performed in patients with known iodine or contrast dye allergies, in those who are dehydrated or if blood urea nitrogen is above 40 milligrams per deciliter or creatinine is elevated, as the dye can further damage renal function. Before the test, bowel preparation may be required, depending on the institution's protocol, though patients are sometimes allowed clear liquids on the morning of the test. Demerol may be given for comfort, and atropine to reduce secretions. After the test, vital signs are monitored, and fluid intake is encouraged, either orally or intravenously, to help flush the dye and prevent urinary retention. Special attention is paid to urine output, particularly the first void, as well as to any signs of hematuria, anuria, or oliguria. The fourth site is checked for infiltration or hematoma, and if any allergic reactions such as flushing, itching, or hives appear, antihistamines or corticosteroids are administered as prescribed. In severe cases, resuscitation measures must be prepared. Upper gastrointestinal series, or UGIS, is an imaging procedure in which the upper digestive tract, from the esophagus to the duodenum, is visualized with contrast. We perform this test when a patient presents with unexplained upper abdominal pain, persistent chest pain, suspicion of esophageal stricture or varices, vomiting blood or passing blood in the stool, unexplained weight loss, poor appetite, persistent nausea or vomiting, or when a mass is palpated in the upper abdomen. It is also indicated for suspected peptic ulcer disease, gastric or small intestinal tumors, inflammatory disorders, small bowel obstruction, malabsorption syndromes, congenital pyloric stenosis in children, suspected intestinal obstruction in infants, hiatal hernia, foreign body, or for evaluation of treatment progress in gastric disease. During the procedure, the patient is positioned on the X-ray table in a supine or upright position. They are then instructed to drink between 8 and 16 ounces of a barium sulfate suspension, which has a chalky taste and can feel unpleasant. As the patient swallows, X-rays and fluoroscopy track the flow of the contrast through the esophagus, stomach, and duodenum. Sometimes a double contrast method is used, where both barium and air are introduced, often by means of a straw with small holes to provide better visualization of mucosal folds. After ingestion, a series of films are taken in multiple positions, supine, prone, lateral, oblique, to coat the stomach adequately and to unfold overlapping loops of intestine. For small bowel series, additional images are obtained every 15 to 30 minutes until the barium reaches the cecum. In enteroclysis, barium is introduced directly into the duodenum through a nasoenteric tube for even clearer images. Contraindications include pregnancy, iodine allergy, lack of cooperation, bowel obstruction, or suspected perforation. Before the test, the patient fasts for at least 8 hours, avoids medications that affect motility for 12 to 24 hours, and is educated about the chalky taste and discomfort of swallowing the contrast. After the exam, food and fluids are resumed. Laxatives or increased fluids may be prescribed to help expel the barium, and patients are told that stools will appear pale or whitish for 2 to 3 days. If stools do not return to normal color, or if constipation occurs, they must notify the physician. Aspiration precautions are essential, and staff must be alert for signs of respiratory distress. Electromyography, or EMG, is a test to evaluate electrical activity of muscles and diagnose neuromuscular disorders. It is used when there is suspicion of muscle disease or conditions affecting muscle function. In the procedure, surface electrodes are applied, and fine wire or needle electrodes, often 24 gauge, are inserted into selected muscles. The electrical activity is amplified, displayed as waveforms on a monitor, and recorded simultaneously on magnetic tape. Typically, about 10 electrodes are placed. Measurements are made at rest, during needle insertion, and during voluntary contraction of the muscle. Nerve conduction studies are usually performed beforehand to measure conduction velocity. The patient should be informed that some discomfort or pain may be felt during needle insertion. Contraindications include patients on anticoagulants or with local infection at the electrode site. Preparation includes a history of muscle function, trauma, or past diagnoses, as well as avoidance of caffeine and smoking for 3 hours before the test. Children may be given sedatives if necessary. The test takes 1 to 3 hours. Afterwards, electrodes are removed, skin is cleaned, and sites are checked for hematoma or infection. If necessary, analgesics or warm compresses are given, and the patient is observed for pain, swelling, or rare seizure activity. Electroencephalography, or EEG, is the recording of the brain's electrical activity through electrodes attached to the scalp. Its primary purpose is the diagnosis and follow-up of epilepsy, as well as the evaluation of altered brain function and brain death. During the exam, the patient must remain relaxed, avoiding facial or scalp muscle movements. 16 electrodes are placed on the scalp, on the frontal, temporal, parietal, and occipital regions, with ground electrodes on both ears. These electrodes are connected to wires and an amplifier, and brain waves are recorded in a resting state, usually with the eyes closed. At regular intervals, patients may be asked to move or open their eyes, but most of the recording is done in stillness. Preparation includes eating beforehand to prevent hypoglycemia, but avoiding caffeine for at least 8 hours. Some medications may be withheld, except anticonvulsants, which are usually continued unless directed otherwise. The patient should wash their hair the night before, avoiding sprays, gels, or lotions. Adults are asked to sleep only about 5 hours, children about 7, and infants should not nap before the test, so they will be drowsy during it. Parents should know that the EEG does not measure thoughts, emotions, or intelligence, but only electrical activity of the brain. The test lasts about 1 to 2 hours. Afterward, electrodes and gel are removed, and the patient can wash their hair. Observations are recorded about seizure history, neurological abnormalities, or sleep disorders. Bone scan, also called radionuclide bone imaging, is a nuclear medicine test that uses a small dose of radioactive tracer to evaluate bone metabolism and structure. We perform this scan to identify unexplained bone pain or joint pain, to detect degenerative joint disease or septic arthritis, and to confirm temporomandibular joint displacement with SPECT imaging. It is essential in diagnosing primary malignant bone tumors such as osteogenic sarcoma, chondrosarcoma, or Ewing's sarcoma, as well as detecting metastases from breast, lung, thyroid, prostate, or kidney cancers. It also plays a major role in diagnosing osteomyelitis of the femur, tibia, fibula, or humerus, in evaluating acute osteomyelitis in combination with gallium scans, in detecting fractures and monitoring their healing, in assessing systemic bone disorders such as osteoporosis, osteomalacia, Paget's disease, or secondary bone changes due to hyperparathyroidism, and in diagnosing pediatric conditions like Legg-Calvé-Perthes disease by monitoring changes in bone absorption activity. In patients with joint prostheses, the bone scan helps evaluate infection, loosening, or breakage. The procedure begins with intravenous injection of a radioactive isotope. 3 sets of images are obtained. The first, called perfusion imaging, captures the initial blood flow within 3 to 5 seconds. The second, called the blood pool phase, is taken within 1 to 2 minutes to show vascular distribution. The third, called delayed imaging, is performed 2 to 4 hours later, when the isotope has localized in the bones. This delayed scan is especially useful in differentiating osteomyelitis from cellulitis. Before the exam, patients are informed of the purpose, the injection, and the fact that scanning begins 2 to 4 hours later and lasts about an hour. They are told that the isotope is injected into the vein and later excreted in the urine. Clothing is removed to avoid interference, and patients are instructed to empty their bladder to prevent pelvic artifacts. After the exam, they are advised to drink plenty of fluids to flush out the isotope. 24-hour Holter monitoring is a form of continuous electrocardiography in which electrodes are attached to the patient's chest and connected to a portable recorder, allowing heart rhythms to be documented during normal daily activities. Typically, the recording lasts 12 to 24 hours. The purpose is to diagnose intermittent arrhythmias, evaluate the effectiveness of antiarrhythmic drugs, study the relationship between arrhythmias and daily life, assess the function of a pacemaker, and detect ventricular arrhythmias during recovery from acute myocardial infarction, thereby estimating future risks. In preparation, the chest skin is cleaned with alcohol, and excessive hair is shaved to ensure electrode adhesion. Electrodes are placed over bony prominences rather than muscle. Wires are attached to a small monitor worn on a belt at the waist or over the shoulder. The monitor contains recording tape or digital memory and batteries. Patients are educated that they must carry the monitor continuously and avoid contact with strong electrical or magnetic fields. They are instructed to keep a detailed diary of daily activities: walking, sleeping, climbing stairs, smoking, urination, defecation, sexual activity, along with any symptoms such as chest pain, dizziness, palpitations, shortness of breath, fainting, fatigue, or anxiety. Each time they feel symptoms, they also press a button on the recorder to mark the event. The next day, the device is removed, the tape is collected, and the recording is analyzed by computer and reviewed by a physician. After the exam, electrodes and adhesive patches are removed, skin is cleaned, and any gel is wiped away. The monitor is disconnected, and the data is processed to produce a detailed electrocardiographic report. The treadmill test, also called an exercise stress test, is designed to evaluate how the heart responds to exertion. It is commonly performed to diagnose coronary artery disease in patients who present with chest pain, or even in those without chest pain, but with suspected disease. It is also used to diagnose arrhythmias, such as tachycardia or bradycardia, to evaluate ECG changes that occur during exertion, to measure exercise tolerance in patients recovering from myocardial infarction or cardiac surgery, and to assess whether high blood pressure occurs during exercise. Additionally, it can help detect peripheral arterial occlusive disease when patients complain of leg pain or claudication during activity, and it is used to evaluate the effectiveness of anti-anginal or antiarrhythmic drugs. The procedure begins with preparation. The skin is cleaned with alcohol, and electrodes are attached to the chest for ECG monitoring. A blood pressure cuff is placed on the patient's arm, and sometimes a mouthpiece is used to measure oxygen consumption. Baseline ECG and blood pressure are recorded, and heart sounds are auscultated. The patient then begins walking on the treadmill while the speed and incline are gradually increased. Throughout the test, blood pressure, ECG, and symptoms are monitored continuously. The patient is instructed to report chest pain, leg pain, shortness of breath, or fatigue. The exercise continues until the patient reaches maximum heart rate, develops significant symptoms, or experiences ECG changes that require the test to be stopped. Afterward, the patient rests in a sitting position for 3 to 10 minutes while recovery is observed. In some cases, repeat testing is done. Patients are asked not to eat, drink, or smoke for at least 4 hours before the test. Comfortable clothing and shoes should be worn. The exam takes about 45 to 90 minutes. Medications that affect cardiac function may need to be temporarily withheld according to physician instruction. After the test, the patient rests, and vital signs and ECG are measured at 3, 10, and 30 minutes. Electrodes are then removed, the skin is cleaned, and the patient is assisted as needed. The head-up tilt test is a valuable tool for diagnosing recurrent fainting, syncope, especially when the cause is uncertain. It is particularly useful for confirming vasovagal syncope, which is a common form of fainting caused by sudden changes in blood pressure and heart rate. It can also help evaluate the effectiveness of medications used to treat such episodes. The procedure begins with the patient lying flat on a special tilt table. An intravenous line is established for fluids and possible medication, ECG electrodes are attached, and a blood pressure cuff is applied. The patient is secured with safety straps. The table is then tilted to about 70 degrees, simulating standing, and the patient remains in this position for 30 minutes, while heart rhythm and blood pressure are monitored continuously. If no abnormal findings are observed, the test may be extended by infusing isoproterenol, a medication that stimulates the heart, in gradually increasing doses at 3-minute intervals for up to 15 minutes. The test is considered positive if the patient develops pre-syncope symptoms such as dizziness, low blood pressure, bradycardia, or actual fainting. At that point, the table is returned to the horizontal position, and the patient is monitored for at least 5 minutes until recovery. Patients are instructed to fast before the test and to discontinue medications that could affect cardiovascular function. Before starting, the procedure is explained in detail, consent is obtained, and the patient's medical history is reviewed. Positron emission tomography, or PET, is a sophisticated nuclear medicine imaging technique that produces three-dimensional images of metabolic and functional processes in the body. It uses radiopharmaceuticals that emit positrons, most commonly fluorodeoxyglucose F18-FDG. PET scans are widely used in oncology for diagnosing cancer, staging disease, detecting recurrence, and evaluating treatment response. Beyond oncology, PET scans also play a role in cardiology for evaluating myocardial viability and perfusion, and in neurology for assessing brain disorders and functional activity. Prior to the exam, patients are instructed to fast for at least 6 hours, with only plain water permitted. Beverages containing sugar, caffeine, or additives must be avoided. Vigorous exercise is restricted for 2 days before the scan. Diabetic patients are advised not to take insulin on the morning of the test, as it can alter glucose metabolism and affect the accuracy of the results. Patients should wear comfortable, metal-free clothing. On arrival, patient identity, medical history, and fasting status are confirmed. A blood glucose level is measured, and an intravenous injection of the radiopharmaceutical is administered. After injection, patients rest quietly for about 1 hour while the tracer distributes through the body, particularly accumulating in tissues with high metabolic activity, such as tumors. During this time, drinking at least 500 milliliters of water is recommended to improve distribution and clearance. The PET scan itself typically takes 20 to 40 minutes, depending on the type and scope of the exam. Patients lie on the scanner bed, which moves through the ring-shaped machine as images are acquired. In some cases, additional imaging of specific regions may be performed.